Hello and welcome to my presentation on pediatric constipation. Let's start by defining constipation. Constipation is a condition in which there is trouble emptying the bowels due to hardened feces. Constipation is a very common diagnosis in children with abdominal pain. It can be a chronic complication in all children. It affects up to 30% of children worldwide. It is the cause of 3% of primary care visits and 10 to 25% of pediatric gastrointestinal visits or referrals. It can cause additional medical and psychological problems. Let's talk a little about the colon. The colon absorbs fluid and transports waste to the rectum. Waste is stored until defecation. Sodium is reabsorbed through active transport channels, and colonic secretion is mediated through chloride channels. This allows the reabsorption of electrolytes and fluids, and stool can be left in the colon and become dry. Dry stool can't pass through the anal canal and can sometimes cause diarrhea. Colonic motility is caused by repetitive contractions. It aids in the absorption and mixing of contents. Larger contractions can bring stool from the ascending colon to the left colon. The stool enters the colon, causing an urge to defecate. Parasystolis, which is the movement of stool, mediates through 5-HT, a neurotransmitter serotonin. This causes a reflex through enteric nerves. It releases acetylcholine, causing muscle relaxation and the passage of stool. Defecation. Defecation requires process of rectal feeling, awareness of rectal feeling, the ability to release stool, and relax the pelvic floor muscles. Anal sphincters, puborectalis muscles, and rectal curvature are all anatomical features needed for defecation. The rectal folds and hemorrhoidal tissues are passive barriers in the anal canal. Internal anal sphincter is made up of smooth muscle and accounts for 70% of the resting anal tone. The external anal sphincter is made up of striated muscle and accounts for the other remaining 30% of the resting anal tone. Puborectalis helps to maintain rectoanal angle and contracts to reduce the angle when one is squeezing. Normally, stool distends through the rectum. It relaxes the internal anal sphincter. This produces the feeling of a need to defecate. The desire for defecation reduces as the rectum relaxes and allows accommodation for more stool. If it is the appropriate time for one to defecate, one will sit, hold their breath, contract their diaphragm. The abdominal and rectal muscles simultaneously relax, EAS and puborectalis muscles. The anus opens and the stool is expelled. What are the causes of constipation in children? Some psychological factors are inadequate fluid intake, dehydration, a diet, the diet where they start to introduce solid foods, an increase in carbohydrate intake, or a decrease in fiber intake. Stool retention due to pain, anal fissures, constriction of external anal sphincter, neurogenic conditions such as cerebral palsy or myelomeningocele or Hirschsprung's disease, endocrine and metabolic disorders and/or medications. Some risk factors for constipation in children include children that are sedentary, children that do not intake enough fluids, children that do not have enough fiber in their diet, children that take certain medications such as pain medications and/or antidepressants, children with anal or rectal medical complications, and children with a family history of constipation. Complications of constipation in children could include anal fissures, rectal prolapse, stool impaction leading to diarrhea, recurrent urinary tract infections, anorexia, enuresis, abdominal bloating, and/or abdominal pain. Psychosocial impact of constipation in children could be due to a major family or life adjustment, such as the loss of a close family member, parents, siblings, grandparents, living in a new situation or a new home, inappropriate toilet training, irregular toilet patterns, physical or sexual abuse, no time to defecate, meaning that They got to keep playing. They ain't got time to go poop. The diagnosis of constipation can be done by evaluating for abdominal distension, palpating for abdominal tenderness, a mass felt in the suprapubic area, which is usually just backed up stool in that area that you can sometimes feel when you're palpating the area. Signs of anal fissures. Oftentimes parents come in and say that their child has had blood in their stool, and when you start to ask questions about how the stool is, whether it's hard or soft, the parent will say, well, they pooped hard balls, and then you discover that it's probably due to an anal fissure or a tear just from the strain of trying to have the bowel movement, and the stool is actually not, the blood is not actually in the stool, it's actually around the stool. But the best way to get a definite diagnosis for constipation in children is an abdominal x-ray, even though x-rays typically are not recommended for children. This is your most definite way to get a good diagnosis. These are just some x-rays as examples of children with chronic constipation. The one on the top there on the right is a before and after picture. You can see how backed up that child is with stool, and then after treatment, a post x-ray was done. The one in the middle is just an outline of all the stool that's in there, and the one at the bottom looks like an impaction down at the rectal area. Management and treatment. So how do we manage and treat constipation in children? We want to establish regular bowel routines. Some children may require bowel retraining. Make sure that they're increasing their physical activity. You want to educate family, parents, and patients of a change in diet. They need high fiber diets with fresh fruits and vegetables. They need to drink plenty of clear fluids to stay well hydrated, and they need to decrease the intake of so many carbohydrates in their diet. Enemas are a good quick fix for constipation, but they don't make the problem go away, and these are usually administered by a medical profession. Most providers don't recommend parents do these at home because there could be some side effects. A bowel clean out can be done. This is usually very traumatic for the child. The child typically gets admitted to the hospital. They get IV fluids, and then an NG tube is put down their nose, and they are administered go lightly until they start to have clear bowel movements. Generally, this can take a couple of days until they actually do have clear bowel movements. And glycerin suppositories can be used. I know some parents do use these. Most physicians I work for don't recommend them, but some physicians do say that it's okay to use the glycerin suppository. The newest fix for constipation in children is Miralax. Miralax is the miracle drug that has come out on the market. It is just a laxative / stool softener. It can be put into whatever the child is drinking on a daily basis. It is odorless, tasteless. It's granules that you mix into whatever fluid they are taking. The important thing to remember is that they drink the entire contents of that fluid in order to get the proper dosing of the medication. It can be used long-term or short-term. Generally, most physicians that I've worked for will recommend that you give the Miralax until their bowel movements are normal, and you can stop it, and then if they start to have complications with constipation again, you can restart the medicine. Some support systems that families and friends or families and parents can turn to are primary care providers, teachers, other family members. Some may need to seek therapy, and there are several online resources. A little note I put at the bottom down here to remember to tell parents is that treatment needs to be consistent, it needs to be aggressive in order to be successful. Families, teachers, primary care providers, and therapists all need to work together as a team in order to prevent reoccurrence of constipation for these children. This is just a picture as an example of what pain could be like for a child that is severely constipated. I have seen children come in bent over in the emergency department. They're in severe pain. They can't straighten their legs out. They can't hardly walk. Oftentimes this gets mistaken for appendicitis, and then we do an x-ray and find out that it's just they're really backed up with stool. This is an example of abdominal distension in a severely constipated child. And this last slide I included just to get a little laugh out of everybody. Apparently June is National Potty Training Awareness Month, and by doing good potty training we can help prevent constipation in the future. This concludes my presentation on pediatric constipation. Thank you for taking the time to listen. Thank you.